Hello everyone, quick lecture on thyroid disorders and a couple other endocrine things. I do have a few slides here on diabetes and a case. I'm going to skip over it for now and I'll come back to it. I'll probably post it as a separate quick lecture sometime closer to the exam. So let's start with thyroid disorders and first talk about hypothyroidism. Hypo is a combination. Hypothyroidism will present itself as a combination of symptoms. It's a pretty basic concept, especially from a treatment perspective. From the endocrine side of things, it's a little bit more complicated. There's a lot of different hormones and structures at play, but essentially what you're going to get is a lack of production of the final product, which is going to be T3 and T4, and then what that's going to do is send feedback so that the pituitary gland is going to kick out a lot more thyroid stimulating hormone, trying to push the thyroid gland into producing more. And ultimately, your lab values are going to show patients who have really high TSH and low T4 is usually the one you measure. T3 and T4, we'll talk about those and the site differences, but essentially you can kind of think about them as the same thing, more or less. They get to the same end point. It also has to do with iodine intake too. So somebody's iodine deficient, they will have some issues with this. So that's a possibility, especially if malnourishment is at play. But usually we're looking at other types of causes, not necessarily just iodine insufficiency. When somebody is diagnosed with hypothyroid, it's usually a lifelong thing. More common in, sorry, that's wrong. I'm going to adjust this right now. More common in women than men, and more common in older women overall. Therapy is pretty straightforward. You just replace the missing hormone. We can do that pharmacologically, and we basically just give people a synthetic version of T4, and then ultimately their symptoms will resolve with that. And we measure the labs to make sure we get them back to a natural physiologic level that's appropriate. Ultimately, when you correct T4, the TSH should decrease as well as things kind of get back into regulation that way. So usually with most patients, you're measuring TSH, and that's going to be your metric for how well your therapy is doing. Also, of course, how they're improving symptomatically. There are a number of factors that can put somebody into a potential hypothyroid situation. So that are just going to require their body to increase production of T4, which might make it seem like they're hypothyroid, but don't necessarily need treatment. However, sometimes if it's severe enough, they might. Pregnancy, estrogen therapy. So estrogen therapy is more common. Probably not going to be associated with like oral contraceptive use and the estrogen in that, but more so like with hormone replacement therapy used for menopausal women, which is a little bit heavier dose of estrogen. Weight gain can cause thyroid issues. There's a few drugs that can increase metabolism. If you know some of these, we haven't really talked about many of these, but these three I think I've brought up, a couple times in the past, and they're all the major enzyme inducers. So they're going to increase the CYP system. So anything that does that can increase the way that the body processes T4 and therefore increase your requirements. And then there's some different malabsorption issues and some other types of disease like autoimmune diseases and irradiation from exposure, whether it be from chemotherapy or from oncology treatments or something of that nature. If you've ever, I should just say as a side note, if you've ever noticed, I think the thyroid gland, and again, I'm speaking outside my realm here, but I think the thyroid gland is particularly prone to getting radiation damage. So if you've watched like Chernobyl or anything like that, or if you've read anything about people who have lived in areas that have been exposed to high radiation, the thyroid issues are probably one of the most common complications that happens. And so if you've ever worked in radiology, or if you guys go to rotations where they're doing any imaging in the room, you'll often see people wearing lead, which is a big lead apron that covers their body, but they also wear a neck guard to protect the thyroid gland. So it does seem particularly sensitive to radiation. All right, but back to what I know more about. Levothyroxine is the main drug we're going to use here. There's a bunch of different generics out there, and some of them are branded, some are not. It doesn't really matter. I've brought this point up a couple times, but I think it's worth saying again that every time you switch generic manufacturers or from brand to generic or something, you probably are going to encounter a slight variance in the potency of the product. So for example, if you have 100 milligrams and you're getting brand name Synthroid, well, that could be 90 milligrams, it could be 95 milligrams. It depends on how stringent the company is. And I won't go out and say that brand name companies are better at this than generic, because that's just not true. But let's just say, for argument's sake, Synthroid gives you 100 milligrams, or sorry, micrograms would be the better way to put it. So you take the yellow pill, you get 100 micrograms of levothyroxine, you switch to Levoxyl, which is a branded generic product, and it's 95 micrograms. Is that going to be enough to clinically matter for most people? Probably not, but it could. Some people have to go with different doses of this, different days of the week. Occasionally you'll see people splitting tablets to get to the right dose, but there are a lot of different standard doses available, so you should be able to figure something out without having to have somebody cut tablets or split tablets during the middle of the week or be on 2 different doses. It's a little unusual, but it does happen occasionally. I say there's some controversy. Usually once you get somebody stable on one brand, switching can be problematic potentially, but ultimately I don't think it's a huge clinical impact. I wouldn't be too scared of it, not as much as I would be if you're switching like a transplant medication, or maybe even like with warfarin, where if you switch, you can see some INR-related fluctuations with that. Levothyroxine is just synthetic T4. It's the same structural thing. It's just made in a lab. It's very bioavailable. There's an IV form available too, in case you have somebody who's NPO. And it's converted into T3 outside the thyroid. Once daily dose, 6 to 7 day half-life, so you can go quite a while, and if you miss a dose, and kind of buffers itself that way. Many different doses are available, as you can see on this chart here. The reason I show you this is because Synthroid is one of the few medications out there that's standard color across any different brands. So if you're buying brand name Synthroid, you're getting the 100 micrograms. That's a yellow tablet. If you buy any generic, it should also be yellow too. The only other product I can think of off the top of my head, and there's probably another one too, but warfarin is like that as well, where all the products have a standard color for the different doses. And so that helps keep things easy for people to remember. And it's easy for me if I'm talking to a patient, I'm like, oh, what Synthroid do you take? And they're like, I don't know the dose, but it's that. Well, I mean, sometimes it's a little complicated, but if they say yellow one, that's pretty obvious, right, or the white one. If they say the blue, then you're in trouble, because you're like, well, is it kind of the bluish purple, or the really blue, or the purple? It's like, who knows how good their eyesight is. So probably not a great way to serve, but at least it keeps things standard when they're switching from one product to another. Levothyroxine is probably one of the most commonly prescribed medications in the country, if not the world, and it's something that you'll see quite frequently on patients. Usually for dosing, I'm not going to test you on this, but because the dosing is a little odd because it is so common, it's probably worth just talking about. It's not as simple as just looking up a starting dose and then working your way up from there, although that is generally the concept. Usually start with a weight-based dose, so 1.6 microgram per kilogram per day for a young adult patient is usually where you'd start. If they're an older patient and you're concerned about the sensitivity and possibly the issue of them getting hyperthyroid, then you might want to start a little younger than that. The 70 kilogram adult would equal 112 micrograms per day. So just to go back to this quick, if you're wondering why there's some odd doses like 112 micrograms and 75 and 88, and like that's right in between 100 and 125, does that really matter? And that's why they did that, because it gives you a little bit more flexibility with the different weights and common things you might see, and also gives you some more options to give people a whole pill to take, so they aren't having to split tablets and things like that. Usually for elderly, again, starting lower than that 1.6 mic per kilo per day. The wide variety observed in practice, so this is just a starting guideline. Doesn't necessarily mean that that's what you're going to absolutely go with, but it's a good benchmark to think about starting with. Correlates best with lean body mass, so patients who don't have a lot of adipose tissue, it's probably going to be more effective with extra adipose weight. It's not really clear on whether that's going to give you an accurate measurement. So for that, let's say you have a 300-pound person versus a 150-pound person. That 300 person is not going to need double the dose as the 150-pound person, because it's more, again, associated with the lean body mass, not necessarily their total body mass. Take on an empty stomach before breakfast. This is really important. It's something you'll see all the time. It's the best for absorption for levothyroxine. And Usually improvement's pretty quick. You might see some impact pretty much immediately. I mean, you're giving your body the hormone it's been missing, so you should see some improvement quite quickly. But usually full improvement and full impact is probably going to take a couple weeks. It may take a few months to get the dose right and to see the ultimate impact on it. If you fail initial therapy, you just increase the dose. That's pretty simple. And you want to watch for overdoing it, so we keep monitoring labs, making sure we aren't going to go into hyperthyroidism. Basically, once you're stable, you check your TSH yearly. You might need to change your dose, like let's say your patient gets pregnant or gains or loses a lot of weight. That could complicate things, and may want to monitor their TSH more aggressively for a little bit until you get things straightened out if needed. Outcomes, it's a highly effective and simple therapy, and it could take months to really resolve some of these things, but the initial symptoms should go away pretty quickly. When it comes to the psychiatric and neurological complications patient may experience with hypothyroid, they might take a little bit longer to catch up, but ultimately they should be reversible. Most side effects are inconsequential and really have to do with over-treating. So that's, again, why if you manage this correctly, monitor your TSH levels properly, you really shouldn't have any side effects at all with this medication. It's pretty benign because, again, you're just supplementing it with something the body already has access to. There's another product called liothyronine or Cytomel, which is a synthetic version of T3. It's not recommended generally. Remember, T3 ultimately gets converted into T4. It's a little bit harder to predict, and it makes serum concentrations fluctuate quite a bit because it's, you're generally converting it into T4, but T4 measurements can kind of be all over the place when you're trying to assess how well this is working. Sometimes people use it in combination with T4. It does get used on its own sometimes for mental health conditions. There are sometimes people who might be hypothyroid and have it associated with depression, for example, and they might get treated with this particular product. Why they treat with Cytomel or liothyronine versus just levothyroxine, it's where the data was, and I think generally speaking you might get a better initial impact with this drug, but ultimately it's a little bit convoluted as to where this one falls into play when you're treating just pure hypothyroid. Armour Thyroid's another product. It's an old medication that's not really used often. I don't think people are started on this anymore, but generally if somebody's been successfully treated with Armour Thyroid, they're probably still going to be on it, so you might see it stocked or prescribed. But for the most part, a lot of these patients have been switched to levothyroxine. And what this is it's desiccated thyroid. So literally it's from thyroids of cows and pigs that they've dried up and processed, and it's mostly going to be T4. It's got about, here's the ratio here. So I've got the ratios of T4 to T3 there, but mostly T4 with some T3. It's dosed in terms of grains, which again is a really old school way of dosing things. And at the end of the day, it's not really important you know this, but just in case you're curious. Again, older generations probably not going to see this commonly. I don't really expect many people would be started on this. The only thing I could think of that might come up occasionally is if somebody has a request to start this product. Maybe they think it's a more natural version than synthetic T4, and we could debate that back and forth, but I would strongly suggest using T4. This is kind of expensive too, and insurances may or may not pay for it. Treatment summary, it's pretty easy. Start with your T4 product, aka levothyroxine, titrate your dose. If you don't respond symptomatically but the labs look normal, maybe consider adding T3 on board, but usually you should be able to get this settled with T4 for the vast majority of your patients. All right, moving on to the other side of the coin, hyperthyroidism. Side effects are basically the opposite of the other symptoms that I showed you. And here's a comparison chart just in case you want to see them side by side. Causes, radioiodine uptake, possibly autoimmune diseases, Graves and Hashimoto's. Some other items I mentioned here, like different types of adenoma, especially in the pituitary gland. If you have very low or absent radioiodine uptake, usually you're looking at thyroiditis. Amiodarone can cause this. Radiation therapy can cause this as well. excessive replacement therapy obviously would be the one that's probably going to be the most common, just because levothyroxine is such a common medication. It's not going to be terribly unusual to see people overdo it occasionally, whether it's incidental or on purpose they overdosed on it, or just dosing that wasn't followed up with monitoring, or the patient was lost to follow-up. Graves' disease, I put some pictures here. People kind of have bulging eyes. It's thought to be a common association with Graves' disease. Missy Elliott apparently has Graves' disease. It's your celebrity fact for the day. Most common cause is of excuse me, of hyperthyroid is Graves' disease. Antibodies get produced against the TSH receptor, and we treat it with a couple different options. First of all, we use beta blockers, because most people, when they're hyperthyroid, they're going to get cardiovascular symptoms, so that helps block the tachycardia, anxiety, the heat intolerance, things people feel. And essentially, it's a short-term symptomatic band-aid until you can get something long-term on, which is what's going to be thionamides, and those are for moderate to severe disease. I'll talk about those on the next slide. Radioiodine therapy is an option, and surgery, if you have a large goiter causing it, that could be an option as well. Thionamides, our goal is to attain a euthyroid state in 3 to 8 weeks, followed by ablative therapy. It may take a couple years to achieve remission without additional interventions. The mechanism of thionamides, they're basically going to inhibit the synthesis of thyroid hormone. They block oxidation of iodine in the thyroid gland. And what that does is it limits the biosynthesis of T3 and T4. And ultimately, you still have some functioning circulating T3 and T4. So when you start the drug, one of these drugs, you're still going to have the body the body's still going to have access to active T3 and T4 and are going to be able to use that. So it's going to take a while for that to get all cleared. So if you have a really high level, know that it's not going to come down. It's not an instant fix, is what I'm saying, because your body has to metabolize all that through its normal pathways. Methimazole is the most common agent. It's preferred because it's got a long half-life. It's relatively convenient. It also reverses hyperthyroidism more quickly than propylthiouracil or PTU. The only time you'd use PTU really is if the patient was pregnant. Otherwise, you use methimazole. But they work the same way. Toxicity of thionamides. Common side effects are listed there. Mostly people might get some itching, maybe some arthritis-like taste, nausea. Not super terrible, except if they're overdone. If thionamides are continuously are not stopped or are dosed too high, they can cause obviously dose-related responses that way. Methimazole is teratogenic, so again we use PTU in pregnant patients. Something called agranulocytosis is a really rare side effect, but when it does happen, we get pretty nervous, or any drug that could potentially cause it, we monitor aggressively for it. So the rate is quite rare. Basically, it's a complete depletion of your neutrophils, and that makes it so your body can't fight infections normally. There's one other drug that causes that called clozapine, but this one also can cause it. And again, it's really, really rare, but it's something that we'd monitor blood counts for occasionally just to make sure there's not a problem. Immune-related vasculitis, not something I'm really concerned, and then a couple other things there too. Iodine therapy. So iodine solution is going to block your will acutely block the release of T3 and T4. You can give this orally. Usually it comes in like a liquid solution. Lugol's is a common brand of iodine solution. It's just a concentration that's been packaged that way. So the max effect is probably about 10 days after treatment. Thionamides and radiation have mostly replaced this. We don't really use iodine. However, in the short term, you might get some effect from it. And if somebody does have an iodine deficiency or something like that, it might help with that part of the treatment. In a preoperative Graves patient, so iodine can decrease thyroid vascularity and decrease risk of thyroid storm. That's one of the things we want to watch out for, because if somebody's thyroid storm is basically a huge output of thyroid hormone and can cause really severe consequences, which we'll talk about here in a second. So we start methimazole before you give iodine. The reason is because iodine helps produce T3 and T4, and if we can give methimazole before, we can shut down that process, and then the iodine can't continue to do that. So thyroid storm, again, it's a really aggressive hyperthyroid picture. It's rare, it's life-threatening. Causes are basically long untreated hyperthyroid. Sometimes there's a surgical or a acute event like trauma or surgery or infection or something like that. Symptoms, standard hyperthyroid, but just amp them up. So we get really concerned about the cardiovascular complications, the tachycardia, the blood pressure, those types of things. So IV beta blockers are the primary therapy. PTU works, is what's recommended in this case, and I think it's because you can give it IV. I'm not 100% sure on that. I've actually never seen it used in this way, but it's possible. I also think it's used because you can titrate it more easily, so it doesn't last as long as the body, so you can get a dose higher and then decrease it off if you need to. So iodine could also be added to IV fluids if you needed to, but I honestly have never seen that done either. Again, this is really rare to see something like this. Glucocorticoids is a more easy practical solution to reduce conversion, and then ultimately you'd want the patient transition to methimazole once they were stable. So that's it for thyroid. There's a couple other endocrine oddball things that I'm not really going to go into detail just because you get things get a little muddy, and we're going to talk more about specific sex hormones in men's and women's health lectures next summer, so that's reserved for then. And so this is really it. Major ones for endocrine are going to be your cholesterol, your thyroid, and diabetes that we'll talk about next week. But there are a few other hormones that of course have impact on various conditions. There's just not a lot medically that I have to say, or not medically is probably the wrong word, pharmacologically, that I have to say about them. And so that therefore, there's all kinds of complicated systems within the endocrine processes, but again, I just don't really have much to say about what we do. We can replace growth hormone and we can replace vasopressin and things like that, but there's a lot of that I'm not really going to talk about right now. So that's it for this lecture. We'll talk about diabetes next week. Thanks.